Good morning and welcome everyone to our final day of the DMHDD Technology Summit. I'm Holly Reif, the Provider Relations Specialist for Assistive Technology, and we are excited to have you join us for this morning's keynote speaker, Dr. Malik Trivedi. I apologize if I stated that wrong, Dr. T, a founding member of Stationmd. As a reminder, we are recording this and it will be posted to our Technology Summit page after the summit is completed. A couple of upcoming technology event reminders to put on your calendar is the AppSy Pro Day on March 24th and the Power Up Conference on April 4th and 5th. There is a Technology Summit survey available on our Technology Summit event page, and I would encourage you all to please fill it out so we can improve our summit for the following years. As a reminder, please post all questions in the chat box to all panelists, and Dr. Trivedi will take questions at the end as time allows. Thank you for being with us this morning, Doctor.
Thank you. Thank you for having me, Holly. I first of all want to thank Holly and the rest of the team for having me on. I very much appreciate the opportunity to talk. I will just preface the discussion here by saying that we are excited to partner with the division. We've always been excited to work with Holly and the whole division's team because I think they've been very progressive in bringing innovative solutions to the state of Missouri. What I'm going to talk about today is very informal. I want to talk about specifically about our solution that I work on, which is telehealth and technology related to that and how it serves individuals with IDD, but then talk a little bit more broadly about technology and specifically disruptive technology. I'm going to go ahead and try, I know this is a talk about technology, but sometimes it doesn't always work. I'm going to try to share my screen and show you guys something and see if this will work. Let's see. Can you see that?
We see the thanks for using Cisco website page.
Yep. Okay. So here's what I wanted to show you all. May seem odd, but
imagine the perfect video stream. It would have a great selection, right? Right. Over 10,000 videos. 3 evening rentals, so no rush, no hassle. Fast checkout. 24-hour quick drop return. Open late every night. Well, the perfect video store is popping up all over the country. There's one near you.
okay, let's see if that worked there. I'm gonna pick on you, Holly. Were you able to see that?
I was able to see that commercial. What a blast from my past. And I heard it pretty well as well.
Okay, good. So you're probably wondering what did Dr. Betty have a stroke? What just happened there? But I did that on purpose to really just kind of highlight something that I think for all of us of a certain age, probably remember fondly going to Blockbuster Video and renting videos and it being a highlight of your Friday night. And I give that as an example of something that is not around really anymore. I think there's one Blockbuster left somewhere, and it's there for nostalgia purposes. But the reason it's not there is because there's a better way, a different way of doing things. And this is one example of what I call a disruptive technology. You guys have probably all heard of Netflix and all these video streaming type services. And the reason we don't have Blockbuster is because there's a technology out there that's technology based that makes it easier, better, more convenient, cheaper to access those same the same experience. So that's one example. And I do feel that when it comes to technology in healthcare, there are some of those disruptive technologies. And the one I'm going to talk about specifically is telehealth. And really why I look at telehealth as a disruptive technology and why I showed you that Blockbuster video is because I do think that for some things, not everything, the use of telehealth is a game changer. It's one of those things where years from now, or even now already, we're going to say, wow, I can't believe that we didn't do this this way. And I think that specifically the application of technology for the individuals that we serve with disabilities is especially important. So I'm going to see if I can share my presentation here. Okay. And Really, this is the goal of all technology, I think, but specifically when I talk about telehealth technology, is to really help achieve superior care for our individuals. I'm going to just briefly give you an introduction about what I do in my background, and then talk more broadly about telehealth. And again, if you have questions, please put them in the chat, and I'll definitely not be using the full allotted time. So there will be time at the end if you have specific questions you wanted to ask me. So a little bit of background about myself. I am an emergency medicine physician by training. I've been practicing for over 20 years. And Stationmd is the organization that we've partnered with the division to provide telemedicine and telehealth support to vulnerable populations. Um, I founded the organization with four other physicians. We are in several states. But what I think is important to mention about our service and any kind of technology, I think, is that behind the technologies are individuals, and individuals need to be trained to understand the needs of this population. And specifically with individuals with IDD, I think that's critical. There's a real unfortunate gap in education in the medical community about understanding those needs of individuals. And whether it's in person or via telehealth or via tech-based, I think that's critical. So, what is telehealth? So, you can read the definition, but essentially, it is the delivery of health-related services, including medical care, education, information, using a telecommunication or digital technology. There's always confusion between telehealth and telemedicine, and essentially they're the same thing. And just to give you a little bit of a background, it's been around for a while. In the early 1900s, there was an attempt to treat a patient after the invention of the phone, of seeing if we can do that. And what's happened recently with telehealth has been kind of an explosion, really fueled by the COVID-19 pandemic. I think this is a technology and a solution that probably would have happened in a few years anyway, maybe 5 years. But because we were forced to do it because of the pandemic, it has really accelerated growth. I think it's important to mention the limitations of this kind of technology, um, procedures, certain tests, um, any kind of technology that we talk about. I think just as important as understanding what the use and the impact it will have, positive impact it will have. I think you have to look at the limitations, and these limitations can be severe. I think understanding those limitations are critical. And then finally, I'm going to talk about the specific issues as technology and telehealth relates to individuals with disabilities that we serve. As I mentioned, that the evolution of telehealth tech. So when I first started getting interested in technology and telehealth, I'll tell you that it was very expensive, big, bulky machines that you would put in a specific room where the person would go into the room and they would be filmed on camera, and it was kind of cumbersome. Now, probably everyone on this call has the ability to do a video call in their pocket on their phone. And so that evolution of that tech has really evolved and has made the use of this kind of technology very, very convenient. I still, and many of us probably have experienced connectivity or issues with whether there's a cell signal or a Wi-Fi signal. And the other part of this is that there's all types of technology and telehealth technology where there's some are video only, some are audio, some are synchronous, some are asynchronous, and that means it's a live call that you participate. Some are where you record the call, but all of these still require some type of hardware and software. That evolution, though, has dramatically facilitated the use of this kind of technology. As I said, it's in everyone's pocket now, but we still have to comply with HIPAA rules. We have to make sure the devices are working, make sure your device is charged. I think the goal of this kind of technology is a goal with any kind of disruptive tech is it has to be easy to use and simple to use. And I think that's especially critical when we talk about the population that we serve. Oftentimes, individuals are not doing the visit themselves. It's being done by a family member, or it's being done by a DSP. And also, I always think that it's very important, no matter how simple it is to use, when you're talking about tech, to have robust tech support, whether that's someone who understands the intricacies of the actual technology, or just simply someone to assist in getting an individual connected, in the case of technology and telehealth, getting connected to the physician. So what are the challenges for individuals with IDD? When it comes to technology and telehealth, and when it comes to any kind of innovation, I think that what happens with individuals with in IDD and in disability community in general, if there's a crack to fall through, they fall through it. And I think that is it's on us to really make sure that this kind of technology and these kind of innovations do get to the people that can really benefit from it. It just needs to be tweaked. I look at this as something that the rest of the community and the rest of the population has really adopted. And I think with minor tweaks, it can be really beneficial, maybe more beneficial to individuals with IDD. I put in here EHR connectivity. That just, I think when you're talking about telehealth, it's important to have some kind of electronic health record connectivity. And we are actually working with the state of Missouri on that. And I already mentioned the live and store forward. These are the synchronous and asynchronous types of technology, telehealth. And then finally, there's what we call remote patient monitoring. These are all adjuncts to add on to a telehealth solution where you can monitor someone's blood pressure, you can monitor their weight, all types of things that you can do remotely that really enhance and really paint a full picture of the individual's health. And lastly, there's these tech first states, and I put this on there because I think it is very important that we have strong advocates, whether they be state advocates, private advocates, advocacy organizations, to really make a push to bring technology to individuals. Otherwise, it's a forgotten kind of sector of the population. As I said, in many of these things, it's really advocates that drive this kind of adoption and use. And I think that the state of Missouri and the division specifically should be commended for doing this. And this conference and webinar is one example of that. So I just want to get into the use of technology and telehealth for individuals with IDD and talk a little bit about really the meat of what I want to talk about is applying that. And for those of you who don't know, and for those who may do know, that this type of social
You're kind of breaking up a bit.
Oh, can you hear me?
Yes, that's better. Thank you.
Oh, sure. Please let me know if you can't hear me. So I'm going to talk a little bit about the use of telehealth specifically in this population to keep people out of the emergency department. And that's really what the gist of what the state has partnered with us, with Stationmd for. And just to let everyone know that this is a waivered covered service now in the state. So why do individuals use the ER? And again, I may be preaching to the choir, but a lot of these individuals have comorbidities, whether they be behavioral, GI, pulmonary, that tend to make them go into the ER and seek care, where you or I maybe are comfortable waiting to get attention. They're complex. There's just a lack of access to medical care otherwise. Even if the individual does have a primary care physician, that physician isn't always available. They may not be able to use the same technology we use to visualize someone, and without that telehealth kind of capacity, the only recourse they have is to say that you need to go to the ER urgent care. Many organizations are also faced with regulatory requirements. These are well-intentioned regulations that provide organizations or group homes or institutions who really have to comply with that have unintended consequences. If an individual takes the wrong medication, will they need to be evaluated by a physician? It could be a vitamin or it could be something more serious. So for all of these reasons, the use of a telehealth solution can really allow the individual to access care in a disruptive, stable environment. And what better environment than one individual home setting? I do want to talk a little bit about the emergency room experience for people in general, but especially for individuals with IDD. I call it the trauma of transport, of just getting an individual to a facility, whether that be an ER, whether that be urgent care. It's extremely disruptive and extremely frightening. For someone that has a sensory issue or someone that's nonverbal, it can be traumatic. Of course, we still have to talk about COVID-19 and exposure to other infections. You're not only putting the individual at risk and exposing them, but you're also exposing that individual who may be vulnerable. And I put in here missed medications. In my many years in the ER, I've seen many individuals come to the emergency department simply for a med refill because they have no other recourse. This visit to these facilities, like I said, it's disruptive, often takes days to weeks to stabilize, and of course puts many people at risk. I'll give you an anecdote and maybe some of you guys can relate on the call that before we instituted telehealth solutions to some of these group homes that we work with, when one individual would go to the doctor's office or facility, everyone would go. Everyone would get in the van and go. And you can imagine how disruptive and how chaotic and really how unreasonable that is to ask everyone to get into a vehicle because one person needs medical attention. So regarding treatment in the ER, I do think that I'm comfortable saying, because I was one of those doctors, it is really unspecialized care. I didn't have the specific training I need to see and understand the needs of an individual, let alone understand the non-clinical world of that individual with a disability. I think your average doctor doesn't know what a DSP is. They don't really know what a group home dynamic and setting is. So it's really unspecialized care. On top of that, as I mentioned, it's traumatic to the individual. It's traumatic to the staff. And what happens is when the individual lands in the ER, they tend to get over tested. They tend to get hospitalized more frequently. And so you have a combination of suboptimal care and excessive costs. And really the goal, as I said, with technology in general, but specifically telehealth and all of these disruptive technologies, is to not only make it easier, make it more convenient, but there has to be some financial component of bending that cost curve, because otherwise it's going to be business as usual. And we hate to talk about finances when you're talking about someone's health, but that is what drives change. I think that we are all convinced that the outcomes for using certain technologies, specifically telehealth, are there. But if it doesn't make financial sense, these kind of solutions are not adopted. I do want to mention COVID since it is still present. This was a study in the New England Journal of Medicine that said that having an intellectual disability was the highest independent risk factor for contracting COVID and dying from COVID. Really alarming when you think of it. The pandemic has been especially challenging for everyone, but especially challenging for the disability community. I'm frankly surprised that this article didn't get more attention in the press, but COVID has been very tough on this community. So regarding telehealth and this technology in general, I want to talk about it in general, and you may have it already through your insurer, your payer, have access to technology and telehealth solutions. It is, as I said, the pandemic has really shone a light on how telehealth can be a viable means of delivering care and really changing the way we operate for many concerns. I would argue the value of telehealth is even more important for individuals that we serve, individuals in the disability community. If it's done right and if it's tweaked to fit and really provide the care that this population deserves. This population oftentimes struggles with finding clinicians who understand their clinical and non-clinical needs. And whether you're in an urban setting or a rural setting, getting to those physicians can be a challenge. Getting to any kind of care can be a challenge. Transportation is a massive issue for this population, and some people require specialized transportation. Telehealth, of course, has no limitations and eliminates that. Sorry. The other part I will say is that it is very difficult. If anyone has ever worked with someone with sensory issues or nonverbal, explaining that they need to see a doctor, and it is a traumatic experience, as I mentioned. And oftentimes, visits that would have taken 6-8 hours can be handled in 20-30 minutes in the individual's home using a telehealth solution. So I only say all this because I do think that the general population, as I mentioned, has adopted this. I think there's no reason that we need to deprive the individuals with IDD from this same type of solution. So how can telemedicine help in general? The lack of access, which is not relegated only to individuals with IDD, but many vulnerable populations really don't have access to physicians because of rurality, because of transportation issues. Telehealth really removes all those barriers, and there are no geographic impediments. As long as there's a cell signal or a Wi-Fi signal, you can apply that kind of telehealth and telemedicine technology. The suboptimal care that I mentioned, I think that in our solution, for example, we utilize doctors who go through specialized training to understand individuals with IDD. using a tech-based or a digital solution, you can access an individual's medical records. I've mentioned this before, and this resonates with many provider agencies I work with and individuals that work with this population. In my many years in the ER, if an individual would come, they would come to the ER with a DSP that maybe knew them, maybe didn't. They would have a big binder that looks like a phone book. I've never read that. No one reads that. It's hard to find information in there. So this kind of solution, really a tech solution, allows you to patch into an EHR that's electronic. You can visualize an individual on one screen. You have access. It's really better care. Our solution, for example, is available 24 hours a day, 7 days a week, and we provide full documentation of all that. All of that is also done via electronically. And I think all of this can be done in the real world, but it's time consuming. It's very challenging for the individual. It's challenging for staff. And as I showed you in the beginning with the Blockbuster video, you can get the same movie, but it's done a lot quicker. And I think as long as you understand the limitation of telehealth, you can get the same care, if not better care, in many instances. I do want to mention that telehealth is not just there for those immediate emergent issues, for non-typical cases, med refills, for example. I've had many individuals, as I mentioned earlier, come to the ER for medication refills, and this can have serious implications. You know, if you don't take your seizure medication, you could have a seizure, and oftentimes these are challenges that this population faces, and the general population as well. Use of technology to solve these, I think, can really impact individuals' healthcare. Med questions, behavior changes, all of these things may seem minor. Constipation. Constipation in this population turns into bowel obstruction if it's not addressed. So addressing these minor issues that you may have not addressed if you didn't have telehealth, meaning, no, I'm not going to go see a doctor because my blood pressure is a little high or because I'm constipated. It's extremely, it's traumatic, it's a hassle, as opposed to just clicking a button and saying, I'm constipated, and the doctor can evaluate you, make sure it's not an obstruction, or refill that medication. These minor cases, because of the ease of reaching a physician, can really impact the overall health of an individual and down the road prevent serious issues and hospitalizations. I just want to talk real quickly about these. This is just something regarding the outcomes of this, and this is just to show that this is not just talk. This actually works in practice. This is our work with the state of Missouri and elsewhere that using telehealth, close to 90% of the calls that we got, just an individual with disability, we have been able to keep those individuals in their home setting, meaning they don't need to be sent out. And that's extremely impactful for many reasons. First and foremost, just outcomes. Improving outcomes on individuals and reducing those just improves the overall care. And you can imagine the financial impact. Just to give you a snapshot of the types of calls that we have received and that you're probably very familiar with. They range from medication issues all the way down to hypertension and falls, fever, constipation. It's very important to understand that these kind of evaluations for telehealth, and this is the philosophy I think you should have with any technology. If it's not as good as an in-person or the alternative, then it shouldn't be done. Not all coughs can be handled. Not all abdominal pain can be handled. I do think, though, that having the ability to address some of these issues via telehealth really impacts the individual, impacts the family, impacts a provider organization. And you can see here, the blue are the ones that are the calls that we received that we're able to keep the individual in their home setting. The gray are the ones that we had to send out. So the overwhelming majority of cases and calls that we got, we were able to keep that individual in their home setting. One other thing I will mention that is a feature that we do at Stationmd, for example, is that if an individual does go out after we see the individual, we will call the facility in advance and let them know that the individual did have a telehealth visit, but just needs an in-person visit as well. I want to go through just an example of a process of how a telehealth visit would work, and then I'm open to any questions you may have, but this would be a real example of how a telehealth case, and this was an example of a real case that I actually had. So this is a 24-year-old female that lived in a group home with cerebral palsy and had asthma. She developed a cough, of a fever of 101, and the SATs were 90%. One thing I will add with this kind of tech-based solution, all of these vital signs, there's equipment out there that you can very simply put on yourself if you're able to, or a family member, a DSP, that can pick up all of these vital signs. They go one step further when some of these are cell enabled or Bluetooth enabled, where those vital signs go directly to whoever you want, to a physician or to the cloud, where they can be kind of evaluated. So in this specific case, that is the change in condition. The activation of Stationmd in our case for telehealth is done via phone call. And the staff usually initiates that. The patient can initiate themselves if they're able to, or a family member. And after that initiation, we get some basic information. And on the bottom, you'd see here is an icon. And this icon would be on someone's phone, can be on someone's laptop. And again, it does not have to be Stationmd. It could be another physician group. The key here is that we want to make this as simple as possible. I think another, as I said, byproduct of the pandemic is that most people are very comfortable doing virtual visits. This conference, for example, is all virtual. Our platform specifically is based off of Zoom, but when we talk about technology like this, it has to be easy to use, but it also has to be compliant. All of our solutions are HIPAA compliant. There's the whole back end of encryption, because again, this is sensitive information that's being passed, protected information, and that alone should be your impetus. But of course, we know that if something is done and that's not HIPAA compliant and it's found out, it can have serious ramifications. I mean, that is something that we're very sensitive of, and all technology has to be sensitive of making sure that those communications are secure. So again, to recap, that's the change in condition. A phone call is just to get some basic demographic information, and then the individual presses this button on their phone or iPad, whatever it may be. In this case, after the button is pressed, the telehealth consultation is initiated. You can see on the bottom, here's an example of it on a iPad. I, as a physician on my end, would see the individual and perform my virtual consultation. I would perform a physical exam. I usually work with the individual or work with a family member to direct these exams. It has been extremely easy to do. We use adjuncts at times, and this is part of the technology that's out there. For example, we have a Bluetooth stethoscope that we employ, but even those remote vital signs equipment, like I said, the blood pressure, the pulse ox, those things are adjuncts. Um, I will tell you that there's some interesting and exciting stuff on the horizon. The use of ultrasound, the use of AI, artificial intelligence. But in this specific case, I did an evaluation of this individual and an assessment, which maybe took 10 to 15 minutes. And in this case, the thought was that this individual had an asthma exacerbation and a respiratory infection. We prescribed medications. That's also done electronically. Those medications are delivered to the individual's group home. In our case, it's not a static evaluation. We would call back the facility and check in on the individual and say, how is the individual? Maybe call back again. In this specific case, the breath sound showed improvement, the SATs improved, the fever broke, and everything is documented. Again, all done electronically. That documentation gets sent to the home. Documentation gets sent to the primary care physician. But the take home here is that a trip to the ER was avoided. I can tell you that this whole process maybe took 20 minutes, half an hour. I'm sure transportation wouldn't have even been arranged for this individual. Very likely that the individual would have sat in the ER for a few hours. Very likely that the individual would have had an extensive workup. And it is not really out of the realm of possibility that the individual would have been admitted to the hospital. Um, Again, I go back to the original statement I made with these disruptive technologies. Is it a more convenient? Is it a more cost effective? Is it more efficient way? And at the end, does the end user benefit from this kind of technology? And I would argue yes. And I would argue that this kind of solution is not um, a substitute. It's superior care in many instances. In ER, I am 20, 30 other people that I'm dealing with. I can't spend the time I want to with the individual. I've heard many times with telehealth that this is the most they've spoken to a physician in their health career, and that's because you are one-on-one with the physician. The one other thing I will add is that using this kind of telehealth, as I mentioned, there's no geographic impediments. You can patch in a family member. So on one screen, I can have the individual. The other screen, I can have a nurse or manager from an agency. On another screen, I can have the individual loved one who could be in another city, another state. And again, these are the kind of things that really make this kind of technology a real game changer in how we deliver care. I will mention that this is very effective. As I said, 90% of the calls we get, we're able to keep the individual in their home setting. But you have to understand its limitations. And it can't be done by a physician who really doesn't have the training to understand both the individual with IDD, but also have had some real world experience. I think this is not something for a new graduate. I don't think that this is something for someone who is not familiar with many of the disease processes. And I do think that it just can't be, okay, let me just FaceTime the individual. You have to have what I call web etiquette, understand how to talk to somebody, how to move the camera, how to visualize, how to get an accurate physical exam. And without understanding those limitations, you can really run into some problems. But in general, I think that for many cases, this has been a real eye-opening experience with family members. I'll give you one or two cases that I want
to. I think you have frozen up on us. Hopefully, you'll be able to join us again soon. Your audio towards the end was reminding me of the chipmunks, so hopefully these technology gremlins will get their feel and move on.
regarding this. Hi, am I back?
You're back.
Oh, how much did you get? Was I talking to myself there for a long time? I wasn't sure.
It didn't seem like a very long time.
Okay. Was this slide up there, Holly?
Yes.
Okay. Okay. So no, I was just saying that I do think that you have to understand the limitations of this kind of technology, and I think that's critical. And especially when we talk about the people that we serve, I think that training component is absolutely critical. Having an understanding of the population, understanding of the limitations, I think is vital. And if you don't, you can run into some real issues. I did want to talk about some of the impact that we've had and in using this technology and just give one or two case examples, and then happy to open up to some questions and may end a little early. But one of the individuals that we work with had a child autism spectrum disorder. And even the mention of going to a doctor's office wasn't mentioned. This was I think a 7-year-old boy that would be dragged kicking and screaming to see a physician for fever or various issues. Mother said it took 2 or 3 days to normalize that behavior. Um, they called us. The child ended up having, I think it was upper respiratory infection, or I can't even remember the exact diagnosis. We evaluated the child, prescribed antibiotics, um, followed up the next day, did another video evaluation. The child was really comfortable because he was in his own home, in his own bedroom. He had his toys around him, his mother right there, familiar surroundings. Um, and the mother was just taken aback, said, he's so cooperative. He's never been this way, because he was in his right setting. And that visit took 20 minutes. This is literally something that was um, a nightmare scenario for her to try to take this child to the office or the ER, the urgent care, and that's something that we handled within 20 minutes. And it has real impact, not only on her, but on the child. And in my years in the ER, have attempted to build autism-friendly EDs, DD sensitive surroundings with decreased stimulation, decreased sensation, light, sound machines, touch objects, all those kind of things. And they're all valiant efforts. And I think I'm glad we did those. But there's no better setting than an individual's home, no safer, more secure setting. And for many of these issues, the adjuncts of technology can really improve the individual's life. Um, the point being with both of these cases, with this case that I just showed you and the case I talked about with the mother and the child, the goal of all of this is to provide the best health care possible, but also to allow that individual to get back to what they want to do, or the family member that live independently, and not waste their time in the ER or in urgent care for hours on end. Um, Technology-based solutions like this really, in my opinion, um, foster independence, foster community integration, and really provide a safety net for this population. Well, as this population is aging, their caregivers are aging. And any kind of technology that we can employ to support that, either formal or informal caregiver, I think we should do. When we started Stationmd, for example, we really didn't realize the impact this would have on DSPs and the DSP crisis. And I think that what is happening in individuals with IDD now, these amazing people that care for this population are making clinical decisions and that they shouldn't be, and then having to go to the ER and sit there for hours. So this kind of solution has impacts beyond just the individual. It impacts the family, it impacts the support staff, impacts the whole provider organization and whole disability community and network in general. Um, so uh, that being said, I think the last slide is just my contact information. I will try to stop sharing here. And see if there's any questions uh, from the audience. And I did want to talk real briefly, if there aren't any questions, or I can start talking about. There's some really exciting new kind of tech-based solutions out there, and you may have heard of them in some of the prior speakers, but I'll give it a second if anyone has any questions. Don't be shy.
I don't see any questions yet.
Okay, that's fine. I did want to talk real quickly about a few of the exciting things that are on the horizon. I mentioned it briefly in the presentation, but they relate to what I call AI, artificial intelligence. They also relate to some of the limitations of this telehealth that right now are not possible in the future. Um, AI, artificial intelligence, is really computer generated intelligence to predict things. And as it applies to individuals with IDD, one of the areas of focus is predicting when an illness will come, predicting falls, preventing those falls. And these are in trial phases right now, where they're balancing some of these tech-based solutions in individuals' home setting with privacy issues, but heat sensors, weight sensors, monitors, slip monitors, monitors on doors. These are all these kind of video technologies where the individual is monitored and really serving as for lack of a better explanation, a tech-based DSP. A lot of these things are being tried in certain populations and really helping alleviate some of the burden that falls on support staff. Some of the really cool ones are actual robotic interventions where they help in assistance, whether it be transferring from a bed or transferring from a shower. There are monitors that monitor the individual's movement. If an individual isn't in a room long enough, then that will be a signal. All of these things, like I said, these technologies have to be balanced with privacy. They also have to be catered and specialized to the individual. And they also have to have some human connection here. That's great if the sensor picks up that the individual fell, but a human being needs to know that individual fell so you can follow up and check in on them. Remote patient monitoring. You can monitor someone's blood pressure or every day but if you don't have someone to act on it, then that technology really doesn't serve its purpose. So, and finally, there are some remote technologies that are being explored where actual procedures are being able to be done. And this is way in the future, but maybe not that far off, where you can get an X-ray in an individual's home, or using robotics, apply a dressing to a wound or change a dressing, all the way to remote surgeries are happening, and the military is exploring this in kind of combat medicine. But all of this is, I think, has to be done with the thought of this technology has to, number one, have the individual in mind, and outcome in mind. Um, and then the other thing I will say that is that I'm very sensitive to, and probably everyone on this call, is all of these technologies are great, but how does it apply to the individuals that we serve? Because they need to be adapted to this population. I almost liken it, the analogy, to ramps at stores and restaurants. They're there so people in a wheelchair can get there. You have to modify some of these solutions so that they can be used by this community. But when done properly, and when backed by whether they be physicians or people who understand this population, it can be very impactful. And like I said, really foster that independence and community integration. So. Well, if there's no questions, I'm happy to end early. I can put my email in the chat if people have any questions. I think I can do that.
Okay. I've got some feedback from last week that folks were having a hard time finding where the next sessions were. So since we've got a few minutes here, I'll let everyone on this call know that when this call ends, this webinar format will end. So to find our next sessions that begin at 10:30, you go to our event page and then click join a session, and that will show you our two sessions that start at 10:30. They're also both being recorded, so if you choose to go to one, but you really wanted to hear the other one, that's okay. You can come back and listen to it later. And then we'll also have a technology fest at the end of the day from 11:30 to 1, where Stationmd will be one of our vendors available to have a one-on-one conversation with. So if you think of questions between now and 11:30 and you're like, oh, I should have asked that question, just jump onto our Tech Fest. You can also find that on our Technology Summit event page, and you can go in and talk with Stationmd one-on-one.
Thanks, Holly. And finally, I do want to thank Holly and her team for doing this. We are really proud of the relationship and the partnership we have with the division. And I can say that this kind of solution is being utilized in other states and areas. And it is really driven by forward-thinking organizations. I'm sure you all know, and Holly and her team know, that there are a lot of issues facing this population. Technology and the application of technology just being just one of them. We talk about COVID and wages and home and community-based services and the changing evolution. So I think having a focus on this is important, because otherwise things don't get changed. It's just a status quo. So thank you for setting this up, and thank you for having me on. Appreciate it.
Pleasure. Thank you so much for your time today.
Thank you.
We do have two questions in the chat.
Oh, sorry, I'm still on. Can you hear me?
Yes, I can.
Okay.
Kat, I don't see them. I just have a thank you
I
so
see
much
it.
for the presentation. Okay.
Yeah, I'll just read the question. The ability to expedite health outcomes and care through the delivery of telehealth. A secondary benefit is the efficient use of DSP, not having to transport, wait, and urgent care. Are you collecting data on how much staffing time is saved for a solution in a DSP crisis? Yeah, that's a great question, and we are capturing that. And some of it is actual hard data where we look at the outcomes of when an individual was kept at home, when they were sent out. And we're also collecting granular data where um, agencies say, okay, if this person would have went to the ER, we would have had to add staff and then backfill, that individual person or pay overtime, or this individual went to the hospital and sat in the ER. And I'm happy to share some of these, but some provider organizations have actually done cost analysis of this, and they've shown tremendous amount of savings using telehealth. Not only is it staffing time and money, but it's also reduced the need for additional staff or overtime. So that's a great question, and I think that's one of the things I mentioned as an adjunct to this kind of solution of a telehealth solution is, we are in a DSP crisis, and that's a national crisis. And anything we can do to support this population and provide them with additional resources is critical. But yes, that's a long-winded way of saying we are collecting some of that data, and I'm happy to share that. Some provider organizations have actually published some of that data. I say published, have marketed some of that data in some of their PR material, and they found a definite savings in time and money. So.
Kat, did you say there was a second question?
No, I don't see anything else.
Okay.
Great. Well, thanks again. Appreciate it.
Thank you. Have a great day. I hope it's warmer in New York than it is here.
Not really, but oh well. Thanks. See ya.
Thank you.